పోటెత్తాలిరా లోకం పెనుకోడి ఖ్యాతిని జై కొట్టాలిరా లెగరా లెగరా మనకు ఆహ్వానం అంటోంది ఆట వదరా వదరా మన తెలుగోడి ఐక్యాన్ని చాట వాషింగ్టన్ డీసీ వీధులు పోటెత్తాలిరా లోకం తెలుగోడి ఖ్యాతిని జై కొట్టాలిరా కష్టాలు వచ్చినా కన్నీళ్లు వచ్చినా భుజాలు తట్టనేస్తమే సభలకు వచ్చినా వితరణనిచ్చినా ఆ మాతృమట్టి కోసమే 90లోనే గీతం వేసి చెట్టైంది ఇవ్వాలిరా ఎన్నారైలా చిన్నలో పెట్టింది దీపాలిరా తెలుగు సంస్కృతికే అండై హోరెత్తిందిరా జగతిన తెలుగాడి జెండా పైకెత్తిందిరా వాషింగ్టన్ డీసీ వీధులు పోటెత్తాలిరా లోకం తెలుగాడి ఖ్యాతిని జై కొట్టాలిరా
ఆకాశమే అక్కై అలరించే ఈ వేదిక తెలుగాడికి ఆహ్వానమంతమే రారెందిక
కళల వైభవం యువత ప్రాభవం ఆట మహోత్సవం జరాలి అందరం చూడాలి సుందరం రెండేళ్ల కోసం భరం విచ్చేసిన తారాలోకం వినోద విన్యాసాలు వచ్చేసిన ప్రతిభకు ఇచ్చే సన్మాన ప్రోత్సాహాలు తెలుగు ఐక్యతకి ఆట చేసే వ్రతం చూడ పలికింది నీకు సుస్వాగతం వాషింగ్టన్ డీసీ వాషింగ్టన్ డీసీ వాషింగ్టన్ డీసీ వీధులు పోటెత్తాలిరా లోకం తెలుగాడి ఖ్యాతిని జై కొట్టాలిరా కొట్టాలిరా
Kiran, you're live.
Hello, everyone. Good morning, good afternoon, or good evening, wherever you are in different parts of the world. My name is Kiran Reddy Pasham. I'm the executive director and treasurer, also the current DC 2022 ATA conference coordinator. And so, as for those who don't know about ATA, it is one of the oldest organizations established in 1990. Primarily to assist and promote literary, cultural, educational, health community activities for people of Telugu origin and also in general the Indian community. And ATA is always in the forefront to do the charity events, and we've been doing it for last 30 years, but especially during the COVID times, we stepped up our community activities even further, and we have done the scholarships, the awareness areas, the blood camps, and many more of those activities, primarily in the US, and at the same time we do look at the India too. So as we speak, there are many representatives from ATA who are doing the charity events. In India, we call ATA Vedukalu and ATA Seva programs there in different cities there. And if you are in India, you can attend the on 26th December in Ravindra Bharati in Hyderabad. ARTA is also doing a grand conference in 2022 in Washington, D.C. We're expecting more than 10,000 people for that conference, especially during the COVID times when people couldn't gather. So we are planning it in a grand way. So we'd like everybody to encourage to come to that conference. And if you're already not a member of the ARTA, encourage to become one. There's a lot of benefits, including the lifetime fitness and the duty-free program there. And we do a lot of yoga activities. There are many things that we do. And with that being said, ARTA is the first one to create these webinars back in almost 5 years back. We are doing it regularly. And one of the topics that we always wanted to do is on the mental health awareness. As you know, mental health includes the emotional, psychological, and well-being. It affects how we feel and act. So it is equally important as a physical health. And so when Banu came with the idea, so we had Dr. Shastri Swaminathan Garu and Dr. Vijay Garu and Dr. Nikita Pant Garu, who graciously agreed to this one. So from the bottom of our heart, we'd like to thank them. And so I'll hand it over to Banu, who is going to introduce the speakers today. And the format will be, we'll have Dr. Swaminathan Garu go first, and then we'll go lectures one after another, different topics, not much overlap there. And if you have any questions, that please, this is live both on the YouTube and also on the Facebook. So please post your questions there. We'll read them at the end of the sessions. This is almost a 2-hour session. So we'll have a good 30 minutes for the Q&A at the end. So please post your questions. We'll take those there. And if you have a very specific question for a speaker, you can mention the name of the speaker also in your question there. So without further ado, over to you, Banu. Yeah.
Thank you, Kiran.
అమెరికా తెలుగు సంఘం
ఆంధ్ర తెలంగాణ ఆట వేడుకల మాసం మొదలైందిగా కన్నీళ్ళే తోడ్చ కష్టాలే తీర్చ ఆట కదిలిందిగా
వ్యాపారం చదువు ఉద్యోగాధికారోగ్య సదస్సులు కళలను హక్కున చేర్చుకు అందిస్తుంటారు ఉషస్సులు నీలతల్లి రుణము తీర్చక కదిలి వచ్చిన ప్రవాసులు 2 నెలలకు ఓసారి 3-4 వారాలు ఆట వేడుకలు ఆట సేవ మరియు ఆట వేడుకలు.
To answer Dr. Swaminathan's question, this is in the YouTube, so it's already recorded by default.
No, he's already live. Banu, unmute yourself.
Good morning, good evening, good afternoon, wherever you are. Thanks for joining the ATA's Mental Health webinar. So we have our distinguished speakers here, and they're going to talk about specific topics, especially the topics include topics related to depression, suicide, and how to cope up with your stress, and then various topics of concern, which will be regarding the mental health. So right now I have, let me go ahead and introduce the chief panelists to you. We have Dr. Shastri Swaminathan, Dr. Vijay Soserla, and Dr. Nitika Pant. So Dr. Shastri Swaminathan is a graduate from the All India Institute of Medical Sciences, and he did his residency in psychiatry at Northwestern University Medical School. He recently retired as chair of Department of Psychiatry at the Advocate Illinois Masonic Medical Center and continues as clinical professor of psychiatry at the University of Illinois, Chicago. Dr. Swaminathan is currently on the board of National Alliance on Mental Illness, on the Leadership Council of the Kennedy Forum, devoted to ending the stigma of mental illness. He has served as the president of the Indian American Medical Association, the Illinois Psychiatric Society, the Chicago Medical Society, and the Illinois State Medical Society. He represents Illinois at the American Psychiatric Association's Assembly and is the immediate past chair of our Illinois delegation to the American Medical Association's House of Delegates. Dr. Swaminathan is the winner of numerous teaching and distinguished service awards. That's Dr. Swaminathan. So let me go ahead and introduce Dr. Pant. Dr. Pant graduated from the University of Illinois, Chicago with a Bachelor of Science in Information and Decision Sciences and a minor in German language and literature. She found her calling as a physician after graduating from college and returned to take pre-medical courses before applying to medical school. In the meantime, she worked in GI Research Lab at UIC and co-authored several academic papers. She graduated from Chicago Medical School at Rosalind Franklin University of Medicine and Sciences and subsequently completed her residency in general psychiatry as well as fellowship training in child and adolescent psychiatry at Rush University Medical Center. Thanks for joining, Dr. Pant. So I have Dr. Vijay Susarla, the other distinguished and a prominent Chicago physician, psychiatrist. Dr. Vijay Susarla has a PhD, and she's a practicing clinical psychologist with office locations in Naperville and Chicago. She has been in practice since 1995 under the practice name Self-Improvement Through Awareness PC. She also founded Manodarshan with the goal of eradicating stigma and promoting mental health awareness in our community. Every month, she does mental awareness talks and is doing research on the Indian diaspora. She just completed a study on the impact of COVID-19 on depression and anxiety in the Indian population in the United States. She has done over 150 community mental health presentations. So with that being said, I would like to introduce Dr. Swaminathan. Swaminathan, please go ahead, sir. Thank you.
Good morning, Banu. Thank you so much for that very kind introduction. Good morning to all of you, my fellow panelists and members of the audience, both here in the US and in India. As Banu mentioned, I'm originally from Tamil Nadu, and I'm thinking about why I got invited to a Telugu association. It's probably because I'm married to a Telugu woman. So that's a good connection to have when you come get invited to these panels here. But my congratulations to ATA for all the wonderful work they've been doing in this country and in India, and especially for doing this mental awareness symposium and webinar, which I think is critical to our community. So this morning, I'm going to spend some time talking about two issues. One is what I call the 800-pound gorilla in the room, which sort of leans in every conversation that we have about mental health, especially access to mental health and being able to get to mental health treatment. And of course, one of the major syndromes in mental health called depression. And I will talk to you a little bit about some of the major signs and symptoms, early diagnosis, possible medications. And then we have some outstanding co-panelists today with Vijay and Nikita to talk to you more about psychological therapies for depression, community depression, and most importantly, teenage and adolescent depression and treatment. So in my humble opinion, there are three reasons why patients don't have access to psychiatry or psychiatric help or psychological assistance, despite having recognizable psychological problems. There are approximately 52 million people in this country who suffer from any one of the multiple psychiatric psychological illnesses. And less than 40%, or a little bit more than 40%, do not access mental health care. In the teenage population, that's even higher. About 60% of our teenagers who suffer from a variety of mental issues do not access treatment. And I have three reasons why these things happen. The number one reason is stigma. The number two reason is stigma. And the number three reason, as you've guessed it by now, is stigma. Because stigma is that central issue that we face as family members, that people with mental illness face as patients, and society at large faces as they deal with mental and psychological issues. And in my opinion, and you can define stigma any way you want to, but I think it's fair enough to say it's sort of a negative attitude, if you will, that we as people who suffer illness feel a sense of shame, guilt, negativity, weakness, and that people around us perceive the same way, and how this in different levels, and I'll explain to you in just a little bit, at different levels of society, how this interferes with access to mental health care. So we have no hesitation in saying, I suffer from diabetes or pneumonia or cancer or infectious diseases or colitis. But very few of us will have the courage to publicly say in a conversation that I have depression, I have anxiety, I have bipolar disorder. Because along with that comes that negativity that we perceive with society in general. So and if that is the case, then we are less likely with that burden on our minds to seek the help of people like Dr. Susarla and Dr. Pant. We're not going to get that help. We're going to stay in the shadows and suffer from that depression and anxiety and mental health issues without seeking the help that we need. And then you have the sort of public social stigma, if you will, which is out there in every aspect. And this is your extended family, friends at large, people in society. And a lot of this is some, in my opinion, of course, is influenced greatly by media. Now, by and large, media in the last few years has been good to us. Celebrities have come out on television, on YouTube, to talk about their depression, about their illness, so people can pick up the courage to go and get the help that they need. But media has also portrayed psychiatric patients as people who contribute to violence, who contribute to difficulties in society. There was a movie released a couple of years ago called Joker. It was a big hit in the public office in the American movie theaters. And Joker portrayed a very sick, very ill, mentally challenged man who committed multiple murders. Now, I can tell you that in all of the psychiatric literature, the percentage of people with mental illness who in any shape or form contribute to violence is 0.0001. That is almost negligible. And yet, when you put on the television, the first question that gets asked when there's a shooting spree in a high school or in society is, was the person who's shooting mentally ill? As though somehow being mentally ill makes you that way. That is an additional stigma that we face as we suffer from mental illness. The other is the importance of stigma in institutional settings. And I'm talking about institutional in terms of workplaces, and I'm talking in terms of hospitals, and I'm talking in terms of the legislature, Congress, political officials. It filters through the whole layer where the attitude towards mental illness often determines the funding source, it determines parity legislation, it determines access to care, it determines a whole bunch of things. And I will talk a little bit about workplace stigma because that is, in my opinion, is so pervasive and so difficult to deal with and causes so much problems in accessing psychiatric care, even when family and patients know that they need that care because of the mental illness they have. Approximately 6 to 7% of the workforce in this country suffers from major depression, crippling, debilitating depression that takes them away from work, keeps them at home, unable to access any kind of help. A very small fraction of them actually seek help through their employee assistance programs or their programs offered a job. Why? Because of stigma. They don't want their bosses to know, they don't want their colleagues to know, they don't want people in the hospital to know. Even within the medical profession, what you tell me as a patient with depression, and I think there's some reason for it, those need to be kept confidential, but yet that sense of confidentiality only applies to sexually transmitted diseases and mental health conditions. We haven't gotten to the point where a medical record should include diabetes and colitis and depression and substance use. We still guard them as though there's something that should be guarded. So that interferes that. Applying for professional licensure, I can tell you, forget about lay professions, even in medicine, in my own profession, the state of Illinois, until just a few years ago, if I put down in my application form, the question is asked, have you ever suffered from a mental illness? And if I say yes, I had depression because my girlfriend left me when I was in the first year of college and I went through holy hell back then. That is 50 years ago. I still have to give a written detailed explanation as to why it's not affecting my curriculum right now. And so that kind of discrimination, that kind of stigma attached to it. There's no other question. You're not asked if you have peptic ulcer or hypertension or diabetes. You're asked if you have mental illness. And I think that's a great disservice to physicians who are trying to access, and this is from our own community. This is people who well know that mental illness is as biologically and as genetically based as diabetes or hypertension or colitis or anything else that you can think of. And still, we have a great deal of difficulty being able to express that in public. As you can see, that important issue that both the patient as well as the surrounding environment, both at work and in family and social setting, begins to become a huge barrier in terms of getting help. Even in terms of health insurance, even in terms of getting coverage, until a few years ago, until Obamacare came along, if you had a history of depression or anxiety, and God forbid, if you made an attempt on your health, on your life at some point, you would simply not get health insurance. And if you do get it, it would be such an exorbitant cost that you couldn't possibly afford it. So you were lost. Even government-sponsored programs such as Medicare and Medicaid would pay physicians differentially depending upon whether you have diabetes or depression. So 80% for diabetes, 50% for depression, which I think is criminal. So as a government, as a political body that represents our people, if we make that distinction, if we say that because you suffer from mental illness, your coverage and your support from healthcare will become less, you can imagine the stigma associated with that and the impact, again, on patients getting access to care. It doesn't matter if you have depression that you're aware of, or your doctor's aware of, or your family's aware of. If you don't have the courage and the will to access that care, then you have not accessed any help at all. So it really comes as a huge barrier in our daily lives. And I tell people that the reason I'm saying this is it's important to us as members of ARTA, as members of the panel, as members of the audience, to be able to have the courage to have those conversations in public. The Kennedy Forum talks about conversations on the kitchen table, that we must make an attempt at every possible public opening to say, I have a nephew who has bipolar disorder. I have a daughter-in-law who doesn't want to get out of bed because she's so depressed. I have a sister-in-law who tried to commit suicide because she was severely depressed, and she has a long family history, genetically based of illness. So these conversations need to occur much more in our community than the local community, but across all communities. We have a problem hiding our mental illness, which is as bona fide, as generally similar to any other physical illness that we have no difficulty in expressing. But those conversations, that awareness, that need to talk to each other freely about our mental health concerns is at the very bottom of accessing psychiatric care with people that you know on the screen today. So I want that to be a really something, a reminder that we keep ourselves reminded every other day and every other week. It's a battle that we need to keep fighting, one that hopefully someday, the darkness around mental health and depression will go away. And we can talk about our mental health issues as freely and as comfortably as we do about any other health issue. Now, one of the things that's this morning that I want to share my time with you, and hopefully subsequently my other panelists will pick up, is one of the major issues that face this country and our community especially, is depression. Depression commonly hits most adults between the age of 18 and 29, although there is no age group, neither children nor adolescents, and certainly not the elder age group, that is immune to this illness. It's pervasive, it's across the board, and it has incredibly disastrous consequences. The cost to this country, the US, every year is about 210 to 215 billion, with a capital B, $billion in terms of lost productivity from our health force that do it, and also direct and indirect costs that money is spent on treating hospitalized patients, patients treated with illness on the office. So the cost, the burden is phenomenal. That comes very close to other major illnesses such as cancer and long-term illnesses that we talk about in our daily lives. So the importance of recognizing, treating, making yourself aware of this illness is incredibly important. And while there are many approaches and theories to what might be causing depression, and over the years we've done much of it, everything from psychological trauma early on, early deprivation, abuse, difficult relationships, conflicts, but also more and more in the realm of pharmacology and neurochemicals in the brain. There is a general sense, and I don't think we have conclusive proof, although most of our treatment is based on that, is that major depression, clinical depression, is largely a function or a result of an imbalance between 2 or 3 major neurotransmitters. These are chemicals in the brain that make transmission of impulses along the nerve system. And they're largely norepinephrine, dopamine, and serotonin. And I don't want you to worry about remembering those names, except to understand that your depression, your anxiety, your bipolar disorder has many, many strong genetic and biological components to it that make it worthy and necessary of getting intervention. Now, simply because it is biologically determined does not mean that only biological interventions work. That's extremely important to make, because I want to, when I get towards the ending of my conversation with you on depression, psychological interventions and therapies, both group and individual, are very effective, extremely effective in dealing with several mental health disorders, particularly depression, particularly cognitive behavior therapy. But there are many others that Vijay will talk to you more about in her conversations with you. Now, I don't want this to be a lecture on depression. I think if you suspect that you have depression, you have access to your family physician. You could call up your insurance company and get someone like Vijay or Dr. Pant to help you out. They will make the diagnosis conclusively. But these are some of the things that I want to leave with you. A sense of, is my son, is my sister, is my father, is my husband possibly suffering from depression? That's a question as a lay public that you need to ask. And if you suspect that, then you need to make the next step, which is to call your primary physician. We do a lot of screening testing. I was talking to my panelists before we began this morning about a patient health questionnaire. It's called PHQ-9, which is freely available, both in workplaces as well as your primary care office and psychologist's office. And it takes you a few minutes to fill it out. You get an early checklist, and you get an early warning sign that you may in fact be suffering from depression, for which you need to get the help you need. Now, one of the key things is you need to separate and try and understand ordinary sadness, melancholy, feeling down, feeling the blues, from what we call a clinical depression that needs medical and psychosocial intervention. Because none of us today on this panel, on the Zoom here, can say we have not woken up feeling like we don't want to face the world. None of us can say clearly that we have not mourned the loss of a loved one and felt intense sense of sorrow, and sometimes to the point of not wanting to do anything with ourselves, but for short periods of time. There are many reasons, from the weather to the economy to the job to loss of relationships, that make us sad. And yet we must make an attempt to separate those ordinary daily blues, as I call that, or sense of sadness, from what we call a more dangerous, a more pervasive, a more serious phenomenon called clinical major depression. And some of the early signs that the patient begins to see is a sense of intense sadness, a sense of spontaneous crying spells. You wake up, you feel like you want to cry. Sometimes you watch something on TV and for no rhyme or reason, nobody else in the room is crying, but you can't stop being moved to tears. A lower drive, you feel suddenly that things are moving very slowly. It takes you a lot more time to get things done. That includes drive of any kind. It could possibly be something more personal, such as a loss or lack of sex drive. Relationships begin to suffer because of that at some point or the other. A personal sense of either an increased appetite or a decreased appetite. They can both happen in clinical depression. So either you don't feel like eating and you start to lose weight, or you eat excessively as a way of dealing with the depression. And that can also contribute to a significant amount of weight gain that you do. You have difficulty in concentration. Things that were much easier to read, a book, for example, seem to be much more difficult to do that. But I think that one thing that stands out as we move on in our trajectory and journey of depression is the sense of lack of pleasure. In Latin, hedonism, hedon is pleasure, and hedonia is a lack of pleasure. So people who suffer from depression don't enjoy things that they normally would enjoy in their lives, whatever that might be. That could be watching television, it could be knitting, it could be sewing, it could be playing with the grandkids, it could be anything you want. But things that give you pleasure stop giving you joy to do on a daily basis. When you begin to feel that, then you begin to notice that is a concern, that you want to talk to somebody about it. Part of the problem with depression, and family members observe this all the time, is that with depression, you also begin to become more isolated. You begin to become more self-involved. And so you're not likely to share your thoughts and problems with other people. And then the next phase, you start to have feelings of recurrent guilt. You start to obsess about the regrets in the past you've had. All of us talk about looking back at our shoulder syndrome and seeing what's going on. But you begin to see that in a more obsessional way. You just can't stop dwelling on how bad you did as a father, how bad you did as a wife, accompanied by crying spells. And along with that sense of guilt is a sense of worthlessness and a sense of hopelessness. Those are a trajectory of increasing symptoms that people feel among themselves and families notice. Families notice a distancing, a sense of isolation, a sense of preoccupation, not paying attention. Often in older age groups, especially, you see much more irritability. People get angry very quickly and for no rhyme or reason. And the underlying thing could be something as simple as depression. But as family members, we're not able to make that projection. So these are some of the things that people encounter with depression. And again, I don't want you to get stuck with what we in psychiatry call diagnosis of depression, which is 3 symptoms of this and 1 of that. But more importantly, to become aware of the early signs and symptoms that would lead for you to access care in a more timely fashion. And last but not the least, and I think both Dr. Pant and Dr. Susarla are going to spend a lot of time talking about both teen and adult suicide in our community. But when thoughts of worthlessness and hopelessness and incredible guilt begin to fester and begin to take a larger portion of your mind, the thoughts of not wanting to live anymore become a reality. And suicide is something that we need to be concerned about. And again, both my panelists will talk to you more about making the assessment in an office setting and taking the next step. But I think there can be no conversation on mental illness, on depression, without having that word. Just to give you an idea, we lose 1 physician every single day. Actually, it's more like a physician and a half. It's about 500 physicians in this country commit suicide every year. So that nobody's exempt from it. Even people who give care to other people go through severe depression and either attempt or contemplate suicide. So it's an extremely important thing to remember. Now, I'm looking at the time clock here. We want to make sure we have enough time for everybody else to talk. But obviously, the approaches to depression are many. Mild to moderate depressions often do extremely well with psychological and psychotherapeutic interventions. And Vijay will talk to you a little bit more about cognitive behavior therapy and some wonderful techniques in terms of early psychological intervention that we have to treat depression. As depression takes more what we in psychiatry call vegetative science, which is more physical science, loss of appetite, sleep, sense of guilt, anhedonia, sexual desire being lost, we think of more medication management, medication intervention. And I have to tell you, when I graduated from medical school, which seems like a century ago, I had 4 antidepressants. That was it. And they were not very safe. They obviously worked wonders. We helped a lot of people. But we were petrified constantly that an overdose of any of those medications would lead to death. So the ratio of the therapeutic dosage and the dose that would possibly result in a catastrophic event was very, very low. And so we were always very nervous and anxious about treating our patients. But we managed reasonably well. We used to also use a lot of electroconvulsive therapy, which may be out of the context this morning, but maybe some of the time we can come back to as a legitimate intervention. But back then we had 4. Around the mid-'80s and mid-'90s, a revolution in the pharmacological companies starting to look at newer antidepressants became an issue. And in the late 1989, 90, Prozac was discovered, and everybody knows Prozac because much is written in the lay literature as well as in movies, et cetera, et cetera. But drug companies largely focus, and scientists largely focus, on those 3 systems that I talked about. Drugs that affect dopamine, and there are 2 or 3 drugs that affect that. Drugs that affect serotonin, that affect your sleep cycle, your desire, et cetera, that largely are the more modern, newer medications, Prozac, Zoloft, Celexa, things of that sort, Lexapro, things we hear. The newer ones, Vibrid, Trintellix, and some of the older ones, some of them are used for smoking cessation, such as Wellbutrin, a dopamine sort of promoter, if you will. The theory being that people with mental illness suffer from a lower amount of these 3 major neurotransmitters, either because they lose them too quickly, they get reabsorbed in the central nervous system in some way or the form, or they don't manufacture enough. But regardless of what the theory is, at the end of the day, most of these medications are focused, and they're highly effective. The response rates to these medications are incredibly strong and efficacious. And primary care physicians, family physicians, internal medicine, OB/GYN, pediatricians, all have the ability to prescribe these medications. And I think they should be your first step in getting care. And they will, when they see as depression becomes more complicated and there's a need to combine more than one antidepressant, maybe increase the dose of one antidepressant to a much larger extent than one would imagine, becomes an issue. And you get referred to a psychiatrist to make those kinds of complex judgments, if you will. Banu, I'm noticing the watch and I want to make sure I'm respectful from other two panelists. So I'm going to stop, friends of the audience here, and Banu and Kiran. Thank you so much for allowing me to share my thoughts this morning with you. I will stay in for the Q&A. I may have to leave a little early. And I told the organizers that if any of you have questions that are pointed to me specifically, just email Kiran or Banu, and they will make sure I get it, and I'll be absolutely privileged to respond to those things to you by email at some point or the other. Thank you again, both of you. And over now to my dear friend, Vijay Susarla, whom I've known for a while, an amazing community activist that I've known, who's done some wonderful work, especially in our community, in helping people, young and old, with depression, conducting superb studies on these issues. And over to you, Vijay. Thank you.
Thank you so much, Dr. Swaminathan. Over to you, Dr. Vijay Susarla. Thank you.
I thought Dr. Pant will go next.
No, Dr. Susarla, it's you.
Oh, okay. Well, thank you very much, American Telugu Association, for giving me this opportunity. I have spoken a couple more times before at a local level for ATA, and it was a great experience. I really appreciate Bhanu Garu for reaching out and asking me to make a presentation today. I was listening to Dr. Swaminathan. It was great to hear him. And when I started practice in this country, I had 100% of my patients were Caucasian or African American. Today, 65% of my patients are Indian. So some things have changed, and I'm very happy to say that. Now, however, every immigrant Indian who comes to my office asks me if I'm going to tell their employer. They're worried that I will release the records to their employer. They ask me, please don't take notes at all, because I might have to release those records to their employer. Every single one of them asks me, will you probably know people in the community, will you be talking to them? Can I trust you to not talk to them about it? So these are some of the things where Dr. Swaminathan was talking about stigma. These are some of the things that are still there. I, of course, assure them that there is such a law called HIPAA, and I will be in trouble. My license will be in trouble if I tell anybody. Every parent who brings their kid to my office asks me if I am going to tell the school. They don't want this to get into the records. And I just want everyone to know that it's a good thing to tell the school, because teachers, administrators, the principal, the counselors, they are so cooperative, and they have the kids' future and well-being in their minds. So I think it's a good thing for us to collaborate. Of course, the parents make the final decision, but it's a good thing to collaborate. Every kid who comes into my office tells me that they simply cannot go to their parents to talk about their mental health issues. And I think that's a tragedy. And I really congratulate ATA for doing this, because I want parents to know that there is a way that they can create an environment in their home where the kids can come and talk freely about any experiences that they are going through. During COVID, there is a significant increase in the number of people who come into my office. I'm working almost 7 days a week, and I have a huge wait list. So there is so much need out there. And I hope more and more people go into the fields of psychiatry and clinical psychology so that they can be of service to the people here. What I thought I will do is to focus on what I do in my office in terms of treatment. I'm a clinical psychologist, so I provide psychotherapy. There are many schools of psychotherapy that have come up with great therapeutic procedures. Okay. One of the most famous is, of course, cognitive behavior therapy. Most of you might have heard about it. Now, basically, cognitive behavior therapy is saying that thoughts create feelings. Okay. We feel feelings first because feelings have all the energy. They're strong. You can immediately feel them. In fact, we are not even aware of the thoughts, the chatter that's going on in our heads, because the feeling is so intense, we feel it right away. You know? However, the contribution of cognitive behavior therapy is that because you have a thought, the feeling follows. So if I think there is danger, then I will feel fear. If I think somebody violated me, I will feel anger. If I think I did something wrong, then I will feel guilty. If I think things are going well, then I will feel happy. So thought precedes feeling. So if I'm feeling depressed or anxious, for example, then it means that behind the depression and anxiety, there are some thoughts. So the next question is, of course, if thoughts create feelings, then if we change thoughts, will there be a corresponding change in feelings? So behind the depression, usually there are very clear what they call schemas. Schemas are ways in which we look at ourselves in general, the ways in which we look at ourselves and the way in which we look at the world. So for example, I can say to myself, I am worthless. If my schema growing from childhood is that I'm worthless, then of course I will feel depressed. I will feel low. I want to hide. I want to run away. I don't want to show my face to anybody. I don't want to talk to people. I withdraw, right? Also, if my schema about the world is unfair, then of course I will not interact the world in the same way if I think the world is fair, unfair, everything put together. Right? If my perception of future is things will never work for me, then I have no motivation to do anything. So usually, these schemas usually are learned right from childhood. So if based on how I think about me and the world and my future and my past, that's how the symptoms of depression and anxiety develop. This doesn't negate genetic predisposition. Also, just because I have genetic predisposition does not mean it has to manifest as depression. There's whole new research being done on what is called as neuroplasticity, where they're saying the brain is plastic and we can change things in the brain. And there is a whole field of epigenetics also, which is telling us that we are not locked into our genes. That in fact, gene expression can change because of experiences in life. So if we create good experiences, then gene expression itself can change. So because thoughts lead to feelings, and if my thoughts are negative, I'll have negative feelings, then what happens is feelings can then distort thinking, right? We know already that when feelings are high, thinking is impacted. In fact, our IQ drops, I think, temporarily. That because when feelings are high, we kind of do stupid things, right? When I'm so angry, I will throw the phone across the room and hurt people, even kill people, right? So when emotions are high, reason comes down, right? And cognitive behavior therapists have developed a whole host of cognitive distortions, what they call. For example, one cognitive distortion would be all or none thinking. A person who is depressed will think either I'm good or I'm bad. Mostly I'm bad. Either the world is good or it's bad, mostly bad. So this is black and white, all or none thinking. When we are depressed, we fail to notice that there's a huge gray area where I can be good at this, and this, and I may not be so good at this, and this. So that kind of distinction fails when the depression is high, when anxiety is high. Right? So this distorted thinking becomes a vicious cycle. I feel, I think I'm worthless, therefore I feel depressed. Because I feel depressed, I feel worthless. So it becomes a vicious cycle. And that kind of makes I forgot to share the slides. Give me a second here. So then, what is it that we do? How do I use cognitive behavior therapy in my office? The first thing I ask people is, if you close your eyes and get in touch with the chatter in your head, what is it telling you? Without criticism, what is the chatter in your head telling you? Usually, there are a finite number of topics our mind flows to when we are, when we give focus to it. A finite number of topics is where my mind goes to. And for a depressed person, it goes to a set of topics. For an anxious person, it goes to a set of topics. So the same thing with, for example, ADHD. It can go in many more directions. So one of the first things we do is that to actually sit down and write down. That is after I get all the basic history. Sit and write down, what are the topics your mind is flowing towards? Then I can use journaling, thought records, logs, depression logs, anxiety logs, sleep logs, these kinds of things I ask people to maintain. If it is women, I ask them to keep a menstrual log, because we know that during periods, emotions can go up and down. So if I am able to understand when it starts, how intense is it, I teach them to rate them on a 1 to 10 point scale, 1 being the least and being the most. And then when they rate their anxiety, panic or anxiety, for example, on a 1 to 10, 8, 9, 10 is very intense, and chances are techniques don't work at the time because we're so consumed by the anxiety. So I try to figure out, using logs, when people have between 1 and 4, 4 and 7, 7 and 10. And then at each state, all these three, there are specific techniques that can be used. Now, then the other thing I do is, once we have the chatter in the mind, we do what's called as behavior experiments, like make a prediction. Tomorrow, you wake up from the bed. Make a prediction on a 1 to 10 how depressed you're going to feel, and then see if the prediction works and is accurate or not, and then introduce certain techniques to see if we can change that from, let's say, 7, 8, 9, 10 to 5 or 6. So those are some of the things we do. Once I know what the negative thinking is, the chatter in the head is, then using a list of cognitive distortions, we see which of them are distortions and which of them are real. So this whole thing is called cognitive restructuring, where we challenge the thoughts, how much of it is real and how much of it is not, and to what degree is it real or not, and then slowly restructure. I also teach them how to replace those thoughts. If I feel I'm worthless, changing it to I'm God's gift to earth is not going to work. So what I need to do is, I'm worthless too. I'm worthless when, and I'm not worthless when. So those thoughts have to be challenged one after another, and then see how you can reframe that. I'm from worthless, oh, I do these things well. What is the evidence that you are worthless? Let's put down the evidence. Believe it or not, majority of the people do not find evidence. And if they do, it is very little that they're exaggerating, using this all or none thinking and saying that, oh, if I did this wrong, then everything is wrong. I most definitely teach calming techniques, deep breathing, guided relaxation, meditation, visualization, guided imagery, these kinds of techniques. I teach absolutely everybody. And I also tell them, don't use them when the symptoms are at 8, 9, 10. I want you to use them every single day. Because if I do not use every single day, I will not be able to use it when I need it. So I teach those things. The other set of things that I also teach are social skills. A lot of people have social anxiety. I teach them social skills. I teach them communication skills, conflict resolution skills, assertiveness skills. A lot of people think that assertiveness means being rude and aggressive. There's a big difference between assertive and aggressiveness. And I teach the difference between the two, and also teach about how to say something without coming across rude, saying something that give negative feedback without coming across rude or demeaning to other people. A big part of depression treatment, there's plenty of research to show that the more active you are, the more you can deal with depression. The more social, the more friends and family members you interact with, the more likely you'll be able to deal with depression. And the more activities you do, the more likely. So I prescribe some daily activities. First of all, I give them a log of what exactly do they do in 24 hours, and then see what I can insert in there, whether it relates to activity or talking to friends or going out. The activities can be at home or out. Going out is extremely important for someone who's depressed because the very sensory stimuli will help them feel better. So I've actually prescribed pleasurable activities. I tell them, identify what the pleasurable activities are, and I want them to do more and more. For example, positive psychology, which is a field in psychology, usually what we have done over the centuries is that we have studied people who had mental disorders. And much of the literature is about mental disorders. Positive psychology said, okay, we've studied people with mental disorders. How are people without mental disorders doing? How are people who are happy? What is different about them and those who have mental disorders? So now there is enormous body of research on positive psychology. And by the way, positive psychology is completely research-based, evidence-based. So they're not just, doing popular psychology or anything like that. Dr. Martin Seligman is the father of positive psychology. He talks about 5 areas on how to improve happiness. So positive emotions is the first one. So I asked, how can we create positive emotions? For example, one of the things I do, I have a bunch of cups. I only date superheroes, is this particular mug. And another one is I postpone homework till the last minute because I'll be older and wiser. Things like, just funny stuff. And when I drink coffee in the morning in one of those cups, it brings a smile to my face. Okay. So I asked them, can we find something like that? Can we do something like that? So we identify 2 to 5 things that they can do that will just bring a smile on their face. And believe me, when I tell my patients that I do this, that this morning I drank a cup of coffee on why does Pavlov have wonderful hair, have wonderful hair, it says classical conditioning. And that savoring of that positive experience again brings a smile on my face. So I want to find little things with people to see how we can promote some positive experiences during the day, and so that's one, and it's a practice, simple practice. Okay. And then Dr. Martin Seligman also talks about PERMA, P is positive emotions, E is engagement. What is it that they can be engaged in? It doesn't have to be earth-shattering. It can be very, very simple. Whatever they have done in the past, we look at it and see, can we revive this? So many women come to my office and say, over the years, I have changed so much. I used to be such a fun-loving person. I had a lot of friends. I was so interested in different things. And then so I looked to see what they have done and then revive those things. R is relationships, how to improve relationships. M is meaning in life. So definitely we go over what gives meaning in people's lives. And A is accomplishment. So I tell all the kids that I see, there is nothing that eats away our sense of self as saying I will do something and not doing that. So it's better to have very, very, very small goals and do them than have this big goal and not do that, because it really eats away at our sense of self. I almost always give my clients homework. The homework can be observe this or that, or one of the positive things that causes positive emotion in us, right? Any number of things I can, or I give them logs and stuff like that. So always I do that. Sometimes I do a lot of role plays. So anxiety, for example, social anxiety, I do a lot of role plays. Okay, imagine I'm your professor in the class listening, and then play both the roles, you know. So a lot of this is, I'm hoping I'm not, please let me know if I'm going beyond my time. The next school of psychology is acceptance and commitment therapy. I honestly think Stephen Hayes just read up on Vedanta and put it in nice package and started using it as acceptance and commitment therapy. He does accept that he read some Buddhist teachings. Now, the basic idea is thought diffusion. So if I think a certain thought, he teaches to develop a distance between me and my thought. So for example, this is my pen. The pen and me is not one. This is my hand. The hand and me is not the same. I'm separate from the hand. So same thing when I say this is my thought, the thought is separate from me. So he trains people into making that distinction. Me from my thought, me from my feeling. And then give me time to take a look at it, whether I want to take it in or not. So these are all mindfulness techniques that that we all know about, and that kind of we are fused with our thoughts, depression thoughts, anxiety thoughts, all these thoughts we're fused with. And he says, let us defuse. There's no such word as defuse. He coined it. Let us defuse and develop a distance and look at them from a distance, and then see them float away, on a. You can visualize a stream going down, and you can see leaves going, flowing away along with the water. And on each leaf, there is a thought that you can place, and all my negative thoughts are going away along with the stream of the water. So there are so many techniques like that. For example, you can visualize you're sitting in your brain, and these leaves are falling, all these thoughts, and you take a nice big broom and sweep them off your mind. There are all kinds of, these are neurolinguistic programming techniques that I use in my office. So I also use solution-focused therapy, where we isolate a problem and we come up with a couple of solutions, practice, come back, see whether it worked. If it didn't, we replace that with something else. I just wanted to go over a few schools of thought: cognitive behavior therapy, acceptance and commitment therapy, solution-focused therapy. And the other one was behavior activation, where I prescribe certain activities that they do. And so those are some of the things I use. There are others, but maybe this is not the time to go over in too much detail. So if my time is up, I am going to hand over the mic back. Before I do that, the depression is what they call wicked problem. That wicked problem is difficult to define. It has interdependencies with so many causes, and it's socially complex, because then if I'm depressed, there is a feedback that I get socially. Now, every problem and every individual is unique. So we have to take that into consideration. This person at this time with this life experience, we have to take all that with this particular problem, all that we have to take it, and it can take time to evaluate. Suddenly patient tells me, oh, this happened. And I say, well, we have done 15 sessions. You're telling me now about this. So it can take time. The solutions are not right or wrong. It depends so much, whether it's better or worse. And there are so many stakeholders in this. Me, my husband, my father, my mother, my children, my friends, my work. There's so many stakeholders in this. right? And the solution itself can cause new problems, right? And whatever data we collect is always incomplete. So it's kind of a wicked problem. So we have to be really gearing it to each and every individual. And with that, I will say thank you very much and hand over back to Bhanu.
Thank you, Dr. Susarla. That was very insightful information, especially, you spoke at length about depression and how the natural science which needs to be looked upon for. And then with that being said, we have another panelist, Dr. Nitika Pant. She she's one of the specialists in the area of adolescent suicides and psychiatry from the perspective. And let me go over her role with you one more time. So Dr. Nitika Pant is an independent practitioner, and she worked at Edward Elmhurst in a variety of clinical settings, both adults and in children, in the emergency room, partial hospital program, intensive outpatient program, as well as her outpatient clinic. Additionally, in her current role, she's an assistant professor at Rosalind Franklin University, which allows her to work closely with medical students to provide mentorship and share her passion and knowledge with the psychiatry. She is board certified by American Board of Psychiatry and Neurology in adult as well as child and adolescent psychiatry. And she has a lot of clinical experience as well. With that introduction, I would like to hand it over to Dr. Nitika Pant. Please take it away. Thank you.
Thank you so much, Mr. Bhanu, and thank you for having me here. Dr. Swaminathan and Dr. Susarla, you both are so accomplished, and I'm happy to be collaborating with you. So let me try to share my screen. And hopefully, do you see that? Yeah, okay. All right, so today we are going to be talking about suicide in children and adolescents. I'm going to go over this with you. There's a lot of overlap between between what I'm going to talk about and some of what has already been talked about. But we're going to go over some facts, risk factors, warning signs, so what you can look out for in a loved one, how to prevent it, because prevention is really, key, and then some resources as well. So facts about suicide, according to the CDC, there has been a 60% increase in the rate of suicide since 2007, and that's in our youth. And it is now the second leading cause of death for children and adolescents, as well as young adults. And it's second to accidental deaths and unintentional deaths. So that's a pretty big, factor when it comes to the importance of talking about this issue, talking about the stigma like we did earlier, and, getting treatment. Now, in children and adolescents, the brain is not completely developed. And the part of the brain that is involved in making decisions, it's the prefrontal cortex, and it's still not as well developed, well into adulthood. So we often find that suicide attempts can be impulsive. So, and this is especially true in younger adolescents and children. Females tend to have more attempts. Males tend to have more completed suicides. The number one method of suicide in young males is firearms. and we'll talk more about that. Versus in females, it is suffocation and hanging. Risk factors. History of mental illness, so is obviously a risk factor. You know, if you have had an episode of depression in the past, you know, or other comorbid psychiatric disorders, whether it's anxiety, whether it's psychosis, substance abuse, it all increases your risk for suicide in the future. Previous suicide attempts increase your risk for suicide. Feeling hopeless, you know, not having a lot of social support increases your risk. Comorbid health conditions, so people who are sick or have physical disabilities or learning disabilities, they are more at risk. Violence and bullying are really big risk factors in this age group. Not just victims are at risk, but the people who do the bullying themselves are at risk, and people who have been both the victim and the bully, you know, they are at the highest risk. So it's very important to address this as well. Family history of suicide is a big risk, and we always make sure when we're evaluating people to ask about, you know, family history of suicide. Relationship factors, you know, if a child has experienced domestic violence, it impacts them not just in childhood, but well into adulthood. Again, you know, as I said, children are impulsive, and a lot of their sense of importance comes through their peers and their friendships and how they are, you know, perceived in that system. And so rejections like a breakup with a, you know, girlfriend, boyfriend, or, you know, a friend group not accepting them. One would think this would not be such a big deal, but at that age, it is really a big deal. A sense of isolation. We can see that with COVID. You know, a lot of kids are really suffering. And, you know, even before the pandemic, they were suffering, but now it's become worse. Lack of support, financial stress, academic stress, etc. All of those increase risk. Community factors, barriers to healthcare, so not having access to therapy or not having access to, you know, psychiatry definitely increases risk. Inadequate community connectedness, so feeling like they really have nobody to go and talk to, or they don't have friends, or people don't care, you know, that can be a huge risk factor. Societal factors, access to weapons or medications is big. And, you know, as we know, it's a huge problem, not just in terms of suicide now, but also in terms of homicides. But that's a different, you know, talk. But, you know, if adults own weapons, then, you know, we have to make sure we have a responsibility that they are secured, and that children and adolescents do not have access to either the weapon or the ammunition. Stockpiles of medications is another way that, you know, this age group attempts suicide. So again, meds at home need to be secured. Unsafe media depiction of suicide. So, you know, these days, suicide in this age group can be glorified. So if your child is spending a lot of time on, you know, watching TV, playing video games, or, just on social media, be aware of what they're doing. There's this popular Netflix show called 13 Reasons Why, which is about a young girl who commits suicide and then goes over her reasons why. And after this came out, we actually saw an increase in suicides in that age group because, kids were watching that show and being influenced by it. And of course, there's the stigma. So if the child has nobody they can trust and no one they can come and talk to, that is a major problem. Or if they're going to feel that they're, judged or shunned, that, that needs to change. So what to look out for? If your child is, or your, loved one is looking very sad a lot of the time, and not just that, in children, we also find they can be just cranky, irritable, they lash out quickly, or they act out, they do things that are not like them. Those are all warning signs. They spend a lot of time in their room. When things get really bad, they might even, not take care of themselves as well. So showering can go down, and, they might not want to go to school. They might complain of headaches and tummy aches and, just feeling too tired to do anything. Their grades are highly associated with how a child is functioning. So, a sudden decline in grades is a big warning sign. Self-harm. Teenagers especially tend to hurt themselves a lot of times when they are depressed or anxious. So self-harm is big, or talking about running away, talking about dying, giving away possessions. Those are all warning signs. And of course, as Dr. Swaminathan mentioned, changes in eating habits or sleeping habits are also warning signs. Okay? So how do we prevent suicides from occurring? We have to take an active role. Communication is key. If you're a parent, talk to your kids, and more importantly, listen to your kids. Don't jump in right away, to try to fix the problem. Just be there, just listen, and, help the child, help your teenager to become more involved, in the sense that, as Dr. Sasurla said, try to get their school involved if you can, or if you're willing, so that they can form more connections, so that teachers and counselors are aware that the kid has a problem and they need help, so increase their supports, have them talk to the school counselor on a weekly basis, or, try to go out and make friends, try to keep them outside their room so that they're not isolating as much, creating a protective environment at home. If parents are constantly arguing or fighting with each other, then they might want to consider getting help for themselves, changing the way they communicate with each other so that it's more of a pleasant environment at home. Communicating with the school, right? We talked about securing guns, securing ammunition, stockpiles of medications. Everything should be locked. The kid should not have access to any of those items. Seeking professional help, so some kids might not be doing well in school, and instead of thinking that they're lazy or that they are just, not no good, try to see what is going on. Try to find the reason why they're not functioning at their very best. So schools will oftentimes do an evaluation if a kid is struggling academically, and it could be that they have a problem with the way they're learning, or it could be, that they have problems with attention, or they can't sit still, they have too much anxiety. So try to get the school involved if possible, if or see a therapist, just like Dr. Cesarla said. It can go a long way to have those coping skills and solution, problem solving skills, right? So medications come in handy if we're talking about moderate to severe symptoms, or if the symptoms are mild, but they've been there and you've tried everything else, hasn't worked, and this is still a problem, right? Causing a lot of distress, interfering with functioning, then you might want to consider medications to help as well. Some resources, there is the Substance Abuse and Mental Health, or SAMHSA organization. ACAP is the American Academy of Child and Adolescent Psychiatry. They have a lot of facts there. There's the National Suicide Prevention Lifeline. It's 1-800-273-TALK. I'm going to say that again. It's 1-800-273-TALK. So if you're feeling like you're suicidal, or you just want to talk to somebody, call this number. Talk to your pediatrician or your primary care practitioner. A lot of times they can take the first step, whether it be medications or connecting you to a counselor. But talk and listen, I can't stress that enough. Here are some of the sources that I used. Thank you so much for having me here.
Thank you, Dr. Pant, for putting together a wonderful presentation. There was very insightful information. So definitely, you gave some pointers, and as you summarized it, having an open communication, whether that be with your loved ones or your kids, and keeping them honest is definitely going to help. And getting the schools involved, if at all it's your high schoolers, or if it's your family members, corresponding, discussing those symptoms and kind of getting help is much needed. I know that the community is kind of stressed out with the COVID and everything. With that being said, I would like to switch to Telugu, because most of our speakers are Telugu. I would like to convert that to a little bit. But so we can take any questions. The panelists are more than welcome to take any questions and answers. And probably if you have any questions, please feel free to post it, either via our Abrtv or Facebook or the Abrtv, and then we'll be more than happy to answer it. And Dr. Susarla can speak Telugu, so she can even answer it in Telugu too. And if you are willing, we can even always convert that into Telugu too, and then check with the other panelists too. But please feel free, ask your questions. If you need any help, please don't shy away. I know that this is a dicey topic, and definitely, with the current situation, with the current pandemic and everything, we are all under a lot of stress, and I know that it has been prevalent across the communities, and it's not a taboo anymore. Thank you. Kiran, would you like to add anything?
Yeah, I think, again, I would like to take this opportunity to thank Dr. Swaminathan, Dr. Pant, and Dr. Susala. And we'll be doing more of these webinars about the health during the next course during the winter till we get to the conference from there. Again, if you're not an ATA member, please do register on our website to become the member, as you can get a lot of benefits with this. And looks like we don't have any questions, neither on the Facebook and YouTube, probably because of the topic, maybe. I think with that being said, I think we are done. Anything else, Banu, from your side?
I think maybe any general topics we can leverage this time. If Dr. Susala, I know that you were trying to present something previously. If you'd like to share your screen and then maybe maybe speak about the science which needs to be looked upon, that definitely would be helpful. But again, so ఎవరికైనా questions ఉంటే కనుక please feel free to put it in the chat. We'll keep this open for a few more minutes, and then మీకు ఏమైనా questions ఉంటే కనుక Dr. Susala and Dr. Pant would be more than happy to help you.
One of the things, a couple of things that I can add. One is
Sure.
Gender differences. Okay, so in women, the prevalence of depression is higher than men. Okay, and women are more likely to talk about their depression. Men are less likely to talk about their depression. Women are more likely to acknowledge to themselves that they're depressed. Men are not likely to acknowledge even to themselves that they're depressed. Women feel more sadness and cry. Men are more irritable than sad, and men tend to not do things, not do anything, not be interested in doing things. Women tend to sleep more when they're depressed. Men tend to sleep less when they're depressed. Please understand that these are broad generalizations, and it can change depending on the individual person. Women tend to eat more when they're depressed. Men tend to eat less when they are depressed. Okay. Women tend to, as I said, they eat more. Men tend to drink more when they're depressed. Women tend to eat more. Women tend to sleep more when they're depressed, whereas men are, I think I told you, they suffer from insomnia. Women they tend to ruminate a lot of negative thinking, whereas men tend to lose interest in hobbies and work, etc. Women tend to feel worthless and blame themselves, whereas men tend to be novelty seeking and sometimes reckless behavior. Women tend to harm themselves more often, whereas men tend to have physical problems, headaches, stomach aches, and things like that. Like Dr. Pant said, women attempt more and men complete suicides more. Women tend to use overdose as their choice, whereas men use more firearms. So those are some of the things that you may want to keep in mind when you see family members exhibiting some of these symptoms, so that you will know what's going on. If you suspect depression, whether it's true or not, really, you don't have to worry about it. You can just get a consult, and the doctors will tell you whether it is cause for concern or not. So when in doubt, please seek professional help. I know this is a very touchy topic, so I want to go a little gingerly at this. When I started my Manodarshan monthly mental health awareness talks, a lot of people came and told me, don't call it mental health awareness talk. Call it stress management or something like that. I didn't even call it mental illness awareness. I called it mental health awareness. Even then people had objection to it. So this is the level of stigma that we that we are experiencing when it comes to mental health issues. One big concern I have is this. When kids say they're depressed to their parents, often I hear parents say that this is just laziness, or they say, oh, you're looking for attention. It's really quite devastating for the kids. Then they also tell them, you don't have any reason to be depressed. I'm giving you everything. What reason do you have to be depressed? So, and then if either depression or suicidal ideation, if a kid expresses suicidal ideation to their parents say, a lot of parents, please understand, I'm making sweeping generalizations, and I want you to understand that that's not my intention. What I saw is that parents, if kid says, I'm feeling suicidal, parent says, why are you doing this to me? Now, a big guilt trip on the child, So now the parents are making it as if it is about them. Now the kid goes and shares with friends. Sometimes what friends do is, they're rightfully so, they will tell a teacher or a counselor. The teacher or counselor will immediately call DCFS, Department of Family Services. Okay. So the minute they get a call, they have to come home and check what's going on. And the parents feel so much shame that the school came to know, DCFS came to know, and they're very, very angry and upset at the child. So this cycle is not good for children. When they say I'm depressed and when they say I feel suicidal, it's about them, not about the parents. Immediately you want to say, what is going on? How can I help you? Do you want to go talk to somebody? Do you want to go to your pediatrician? What would you do? Did you talk to your school counselor or social worker? That is what the response should be. Not, why are you doing this to me? You're only looking for attention. And let me tell you one other thing about attention. If somebody is doing something drastic to look for attention, my immediate question would be, why are they looking for attention? What's going on here? Not dismiss them, say, oh, they're just looking for attention. So it's very important that we are sensitive about this, especially with our kids. So I don't know if Dr. Pan, do you want to add anything to that?
Yeah, I couldn't agree more. I've actually worked with parents, who are incredibly supportive. And then on the flip side, I've worked with parents whose kid committed suicide or attempted suicide, sorry. And they thought nothing of it and brushed it off and, followed up in clinic 3 months later, right? So even if the child is doing it for attention, it means that there is still suffering involved. Means that they still need help, and exactly why are they doing it? Try to find the reason behind, try to make them feel validated, and supported. And put the child's needs ahead of your own or ahead of society's, right? And if you're a kid listening to this or an adolescent listening to this, and a friend reaches out to you and they're suicidal, please know that there are no secrets when it comes to suicide. And you would rather have a friend be really mad at you and maybe even not talk to you than, have no friend at all, right? So talk to a trusted adult, try to see if you can, have that adult connect that kid with help. So don't take it upon yourself to treat them.
Bhanu, if you want me to stop, I will, but can I add one more thing? One of the most important things that I see in my office is the immigrant first generation communication. And for no fault of their own, after all, we have come from India, and what I have in my mind is what I have learned before coming to US. And I'm kind of frozen there, right? Most of us are frozen with that. And we try to teach whatever we did to our children. And also, education worked for us. So we want to make sure our children are educated. So that is our background. Now, the child is living in this country. Majority of the time, the child is spending in the major culture. And in fact, a child would want to identify with the majority culture, not with the minority culture, right? Now, so therefore, they are taught independence, being able to speak frankly and openly, being able to give feedback. It doesn't matter whether it's older or younger. So that hierarchical structure is not taught out there. Whereas in the house, they're constantly saying, you cannot do this, you cannot do that, you cannot put your feet up, or you can, a number of rules. Now, these are quite contradictory in the child's mind. And they have to make sense of this, right? And they are having a hard time making sense of that. So it is up to us parents to figure out what is the middle ground. On the one hand, it differs from family to family. But on the other hand, as an Indian community in an American culture, what is it that we will adopt and what is it that we will retain is something that we really, really have to think about, talk about, come up with some kind of a model that we can present to an immigrant. So, then they can say, okay, this is what we can do. This is what will be good. This is the via media solution. So I really want to see that kind of a dialogue take place among immigrant Indians. And I think it's really up to us parents. We can't just put it on the kids, So that's another thing I just wanted to put forth because there are so many wonderful organizations doing great service work. And I really think we need to add this as one of the projects. Okay, thank you.
One last thing I just wanted to add that, we may not have touched upon as much as drugs and alcohol, because there's stigma associated to mental health, like depression and anxiety, and deeper yet is the stigma associated with drugs and alcohol, right? But if you think that your teenager is not doing it, that's really great, and I hope they aren't, but it is possible that their friends are. And if they get invited somewhere, it's possible that they might, be introduced to it. So having a conversation with your kid, an open and honest conversation where they feel comfortable coming to you and talking to you about it, instead of going to somebody else, or having secrets, goes a long way in protecting everybody's mental health.
Absolutely. Mental health, drugs, sex. We have to talk to our kids about. Well said, Dr. Pant.
Thank you so much, Dr. Susadla Garu and Dr. Pant, for providing so much insightful information. Definitely, opioid addiction is a major thing that's going on out there as well. And definitely, in addition to the mental health awareness, that's another topic that needs to be discussed at length. But definitely, thanks for all the insightful information regarding the depression, the suicidal tendencies, which we have to note for. We really do appreciate all our panelists, Dr. Swaminathan, Dr. Susarla, and Dr. Pant, for taking time and coming forward and helping us out, the community, from this perspective. We really do appreciate it. On behalf of ATA, Kiran, would you like to add a few points?
No, absolutely. I think it was a great webinar in my view. I think one of the unique ones that we have done, and I'm sure our audiences will be greatly benefited from this. And it's a recorded one. It's there on the Facebook and also on the YouTube. So more and more members can see at the later stage also. So again, thank you.
Thank you so much, guys. This will conclude our webinar. Thank you.
Thank
Thank
you.
you.
Bye-bye.
Bye, everyone.
అమెరికా తెలుగు సంఘం
ఆంధ్ర తెలంగాణ ఆట వేడుకల మాసం మొదలైందిగా కన్నీళ్ళి తోచ కష్టాలే తీర్చ ఆట కదిలిందిగా
వ్యాపారం చదువు ఉద్యోగాధికారోగ్య సదస్సులు కళలను హక్కున చేర్చుకు అందిస్తుంటారు ఉషస్సులు. నేలతల్లి రుణము తీర్చక కదిలి వచ్చిన ప్రవాసులు 2